Hello, everyone. I am Charlie Revis, President of Dysphonia International. Welcome to all of you to our webinar that's titled Botulinum Toxin Treatment Options for Spasmodic Dysphonia. The webinar is being recorded and will be available on our YouTube channel and website, which is dysphonia.org. We encourage your questions, and you can submit them by typing in the Q&A box on your Zoom screen. And I want to emphasize to you, please put your questions in the Q&A box, not in the chat. And we will answer as many questions as time permits. However, I want to assure you that all questions will be answered and made available as part of the webinar on our website. I am absolutely pleased and delighted to introduce our guest speaker for this webinar, Dr. Stephen Bielamowicz. Dr. B received his medical degree from Baylor College of Medicine, completed his residencies in surgery and otolaryngology at UCLA. He continued his training by completing a fellowship in neurolaryngology at the National Institutes of Health, with special interest in the physiology and modeling of laryngeal function. Dr. Bielamowicz is professor and chief of division of Otolaryngology-Head and Neck Surgery, and also division director of otolaryngology at George Washington University in Washington, D.C. He has served as program director of otolaryngology residence at George Washington and is a member of several national societies, including the Triological Society and the American Laryngological Association. Dr. Bielamowicz has presented research papers at numerous national and international conferences. His research interests include laryngeal biomechanics, image-guided surgery, and the neurology basis of laryngeal disease. Dr. Bielamowicz serves as a member of Dysphonia International's Medical Advisory Board, and we're pleased to have him conduct this webinar for us. Dr. B.
Thank you very much, Charlie. It's great to see you again. We've met in person several times, but it's been quite a while. So I'm going to begin sharing my screen. Today we're going to talk about botulinum toxin in the management of spasmodic dysphonia, as well as a little bit on vocal tremor. So spasmodic dysphonia is a neurological movement disorder affecting the voice, and it's characterized as a focal dystonia. And other focal dystonias that people are oftentimes familiar with include torticollis, blepharospasm, which is an uncontrolled closure of the eyes. And the most common focal dystonia that almost all of us have experienced at one point in time in our lives is that of writer's cramp. Certainly it was true of my generation. I'm not sure that my children's generation will ever have experienced that, given the fact that they grew up typing on a computer and writing papers in third grade on the computer. So spasmodic dysphonia is a spastic activity of the intrinsic laryngeal muscles that occurs during phonation. It's associated with a concurrent vocal tremor in somewhere between 30 and 50% of patients. The typical age of onset of a patient with spasmodic dysphonia is 30 to 50. From my own clinical experience, the youngest patient that I've ever diagnosed was a first grader, and the oldest patient I think I've ever diagnosed was around 80 years old. So spasmodic dysphonia is typically subdivided into its two basic subtypes, and that includes abductor spasmodic dysphonia and adductor spasmodic dysphonia. So abduction is the movement away from the midline. So in this particular screen here, this is the open vocal cord position. So this is the position that the vocal cords will go into to lose voice production. So as a result of losing voice, there's breathiness to the voice or breathy breaks. With adductor spasmodic dysphonia, which is by far the more common of the two spasmodic dysphonias, there is an issue with the closing of the vocal cords. In fact, the vocal cords overclose. They have a spastic overclosure of voice production that interferes with voice production. And rarely we will see a patient that has a mixture of both abductor as well as adductor spasmodic dysphonia. And those patients that I've seen with this, sometimes they'll purely present with abductor symptoms and then develop adductor symptoms or vice versa. But again, this population is less than 1% of all patients with spasmodic dysphonia. The diagnosis of spasmodic dysphonia is a characterization of voice production with the spasmodic dysphonia breaks. The vocal tremor is a modulation of the voice. The most famous actor, actress that I can think of from my growing up was that of Katharine Hepburn, who had a significant vocal tremor, who in her younger years, certainly in the black and white movies, when she's going down the Amazon, she had no problems with her voice. But when she's calling about the loons on Golden Pond, she had a really significant vocal tremor as she became older. So again, that is essential vocal tremor, which is tremor without spasmodic dysphonia breaks. But in patients that have spasmodic dysphonia breaks, we can see a dystonic tremor affecting somewhere between 30 and 50% of the patients. So that the diagnosis of adductor spasmodic dysphonia, there's no specific test. There's not a blood test, like we can't swab you for COVID. We can't take a blood sample and get a diagnosis of an infectious cause. But instead, we have to diagnose by speech symptoms. So we're looking for a voice that has kind of a classic pattern of speech, and that demonstrates a strained or strangled voice quality. There's oftentimes a difficulty initiating speech, and voice breaks with frequent voice interruptions occurs during connected speech. So one of the classic sentences that Dr. Christy Ludlow, my fellowship director at NIH, came up with is, "We mow our lawn all year." And this is true of the people that live in the Pacific Northwest. You have to mow your lawn all year. Here in the Northeast or mid-Atlantic area where I live, I just mowed my grass for the last time this past week. So if we look at a sample of that sentence in a normal person, the top channel is the acoustic channel. So again, this is just a microphone representation of the power that's used to make the sound. So we can see with increased intensity or activation of that pattern, we see we mow our lawn all year. So again, it's a very nice, smooth utterance with breaks between we mow and our lawn and all year. And these are the EMG channels that are associated with the voice activation. So these are the thyroarytenoid muscles, the right and the left. And these are the cricothyroid muscles. And again, this is a respiratory channel. So again, we speak on exhalation. So we start here and our airflow falls as we say this utterance. And this utterance is taking this particular person 3 seconds to speak. Interestingly, the EMG channel tends to precede the acoustic channel by about 200 milliseconds. So the initiation here is about the same as here. And so that's kind of the offset that you have to figure in when you're looking at these samples. So this is the samples of a patient with adductor spasmodic dysphonia. So most remarkably, and again, this is part of the symptoms associated with this illness, it's taking this person 7 seconds to take that, to make that same utterance. So if I'm planning on speaking for 45 minutes for this particular presentation, it's going to take me with spasmodic dysphonia over 90 minutes to say the same thing. And that's effortful, that's tiring, that's inefficient, and frankly, it's very frustrating. So again, with this utterance in the acoustic channel, we can see we, then a big break, and then oh, and then a big break, and then on, a big break, oh, ear. Very little sound production with year. And what you can see as opposed to the smooth, I'll go back, as opposed to the fairly smooth EMG activity that occurs through this utterance within these muscles, if you look at just the right thyroidnoid muscle, you'll see it's really choppy. And these are all kind of bursts of electrical activity that are the spasms that occur that are responsible for affecting speech. Abductor spasmodic dysphonia, which is the other type that we'll concentrate on in this particular presentation, is characterized by prolonged voiceless consonants. So we have 4 in the American English language, H, K, P, and T. And so these are voiceless sounds. So it's so when you say H, like in heavy, then H is an opening of the larynx. And then the problem with patients with abductor spasmodic dysphonia is that they have a failure of activation of the closing muscle with their normal timing sequence. So some of the words that are difficult are Harry, Helen, Karen, Tom, party. So those are all words that can elicit abductor spasmodic dysphonia breaks. So again, it's difficulty initiating vowels after voiceless consonants with an intermittent or persistent breathiness that occur in some patients. A persistent breathy pattern is seen in less than 10% of patients with abductor spasmodic dysphonia. And that's the one group of patients that can undergo surgical augmentation of the vocal cords to enhance overall vocal cord closure, just like we treat patients with vocal cord weakness or patients with aging change, and we can affect a good long-term outcome with a surgical option. Again, something that I've done in a handful of patients and have seen some really good successes with that. So we always perform a fiber optic laryngeal examination. What we're looking for is a normal laryngeal exam that occurs both at rest and with what are characterized as vegetative tasks. So these are non-speech tasks. So a whistle will result in your vocal cords just being open. A cough will result in just an overclosure of the entire throat, including the larynx and the supporting structures of the larynx, as well as some of the throat tissues. And then the respiratory movement of the vocal cords would also be normal in patients without tremor. In patients with tremor, they may actually have evidence of a tremorous activity that occurs at rest, which in actuality is not really rest because we're always breathing. So again, this is something that can be seen in patients that have vocal cord tremor. Without tremor, the larynx looks normal during respiratory activity. With adductor spasmodic dysphonia, the laryngeal examination will typically show an overclosure of the structures above the true vocal cords, the supraglottic compression. Intermittent overclosure is associated with voice stops. And so those are those breaks that we were seeing in that speech sample from the patient with the EMG activity. Abductor spasmodic dysphonia can result in poor vocal cord closure with breathy breaks. And again, some can have incomplete vocal cord closure. The cause of these illnesses, again, I did that fellowship in the mid-90s. Here we are in the mid-2020s. And I was really hoping by now we would have an answer here. We're getting some insight into what can cause some of these problems and some of the disordered brain activity that occur, but actually what causes this illness? We know that it seems to have a very poor heredity. It's very, very rare to find a family. I have run into a few in my career, but it's very, very rare for patients with a focal dystonia that runs through the family without having a multifocal dystonia type of a syndrome. So again, the causation is unclear. Many illnesses are two-factor. There is a genetic predilection, and there's an environmental impact. That's certainly felt to be the cause of a lot of cancers, so lung cancer, a predilection to develop cancer, plus you smoke, gives you a high likelihood of developing cancer. If you never smoke, you have the genetic predilection, the chances of developing the cancer are very unusual. But again, what it is that causes these focal movement disorders, regardless of which one we're talking about, including spasmodic dysphonia, is very unclear. And it's very frustrating to me that I keep giving this particular slide. We can look at the actual EMG motor unit activity of the larynx and the muscles, and typically they're normal motor units. We don't see anything that's specifically abnormal about the individual motor unit activation, but we do see issues associated with the way they're clumped together. So the pattern analysis, where we're looking at the EMG pattern over time, that's abnormal. It's to the individual neuromuscular activity that's normal. So what are the treatment options for spasmodic dysphonia? There's medical therapy, there's voice therapy, botulinum toxin therapy, and there's surgery. So the focus of this talk is going to be on Botox. Again, that's what I have the most experience with in my career of taking care of patients since the mid-90s. So botulinum toxin is a Clostridia toxin. There's two primary Clostridium toxins that we know about, botulinum and tetanus. They have similar activities in that they cause paralysis or weakness of muscles, but there's a main difference. And again, I'm not going to go through this aspect of these medical slides, but tetanus causes a spastic paralysis. And again, this is the reason it's also called lockjaw, because one of the early symptoms that you cannot open your mouth because your jaws are clamped shut. And so again, that's spastic paralysis. It's an inability to move the muscles because they are persistently over tightened. Botulinum toxin, however, causes a flaccid paralysis or a weakness of the muscle. So if a baby ingests honey, which is contaminated with botulism, and develops an episode of botulism, then the baby's going to come to the emergency room and it's going to be a floppy baby. The baby's not going to have great neuromuscular tone. The baby may have some problems breathing, shallow breathing, because again, the muscles are over weakened, and that requires support. There's different serotypes of botulinum toxin. There's 8 different serotypes. The one that we typically use in the office is botulinum toxin type B. A and F have been used in clinical settings, but do not show any significant benefit in duration of effect or side effect compared to B. So that has never really gone into a market type of a scenario. The incubation time for botulism is 18 to 36 hours. And so again, this reflects the time of waiting after a Botox injection into the throat before you have a weakness of the voice. So typically somewhere in the order of a little less than a day to about a day and a half or so, you start having some changes in voice production after an injection of Botox. Botox type A remains viable within the cell for 80 days. And what happens once that Botox is injected, it's brought in through the neuromuscular end plate. This is the end plate between the axon of the nerve and the actual myocyte or the motor muscle. And so it's brought into the nerve, and then that prevents the release of acetylcholine. Acetylcholine is necessary for the contraction of skeletal muscle, and Botox in the larynx is treating skeletal muscle. And so that results in a inhibition of the ability of acetylcholine to be released and results in the weakness or a flaccid paralysis. So botulinum toxin as a treatment for adductor spasmodic dysphonia blocks the signals from the nerve to the muscle. We inject Botox into the vocal cord muscles that are responsible for closing. So again, we've talked about the thyroarytenoid muscles. So these are these vertical stripes that underlie the lining tissue of the vocal cord that we see on a laryngeal examination. And there's a whole set of what we call intrinsic muscles of the vocal cords, but it's the thyroarytenoid muscles that are primarily responsible for voice production. And the Botox unplugs the nerve from the power source. It's a temporary treatment. It's effective for only about 3 to 4 months and requires repeat injections to maintain a persistent effect. Unfortunately, there's an over-injection effect that occurs after the initiation of the botulinum toxin in the muscle, and this results in side effects. So the side effects can include voice weakness, hoarseness, as well as a tendency to have difficulty swallowing liquids. So the primary symptom associated with liquid food swallowing issues is that of having a tendency to get liquid into your airway, making you cough. So again, the system protects itself from developing pneumonia, but you have to be very careful not to drink very quickly, keeping your chin in a neutral position as opposed to an elevated position, as occurs when you drink out of a glass of water that has ice in it and you're trying to get the last of the water out of the bottom, is something that is a real acrobatic feat of the throat to prevent us from aspirating. And when you weaken those muscles, that's something that is very difficult to navigate. So keeping the chin down, even drinking with a straw to keep your chin down to allow you to remove all the fluid out of the bottom of your beer bottle. That's what some people have to do. Adductor spasmodic dysphonia, Botox is beneficial in 95% of patients who receive benefit. The best voice in some patients can be a normal voice. It's a dose-dependent effect and side effect. However, the majority of patients have significant improvement in voice, but really don't have a full normalization of voice. You can treat the same patient for 3 times a year for 10 years in a row, and occasionally a patient will come back and say, "Doc, that was the best Botox treatment I ever had." And I said, "What do you mean?" I said, "Well, I didn't have any side effects. My voice just got smooth. It was kind of like my old voice again. I forgot I had a voice problem for a bit of time, for about a month or 2. And then I started noticing a little bit of tightening of my voice. And then I started getting voice breaks after about 3 or 4 months. So I'm back again." And that's a typical scenario of Botox as it's used in the management of adductor spasmodic dysphonia. There are different methods of injection, and transoral is an old technique from the 1920s, requires anesthesia to the inside of the throat. Certainly this can be performed in the operating room under general anesthesia, but the majority of practitioners would push towards office-based treatment because no one wants to go to sleep 3 times a year to have your spasmodic dysphonia managed. And again, the treatment recommendation for transoral is based upon the physician that you're seeing and their experience. I was talking to a good friend who's at a very solid institution in my area, and he was saying, I need to come down and watch you do EMG Botox. I didn't learn that in my fellowship. I knew how to do transoral very, very well. So again, that's what he offers. And you don't want me to do a transoral injection. I've got like zero experience. Something that we really hardly ever did at any point in time in residency or in fellowship. In fellowship, it was all EMG guidance. And most of what we would do most people do is a transcricothyroid membrane approach, where we go through the kind of below the big cartilage of the larynx, above the small cartilage of the larynx, kind of just off midline, and use EMG to confirm placement in an active side of the muscle. And then some people will do a transcartilaginous injection with a fiber optic visualization. And that's a technique that Dan Green, who's a resident above me at UCLA, and Jerry Burke popularized. And that's where they go straight through the cartilage at the attachment site of the vocal cord. And there's a few people that have mastered that quite well, and that's the technique they use, and they have very good outcomes. And again, most of us who've been in these worlds for a long time, patients move around, especially here in the DC area. So I've taken over the care of many other providers, and all of these techniques can be very, very effective. There's two different approaches to Botox for adductor spasmodic dysphonia, and that is a one-sided injection or a both-sided injection. So it's oftentimes patient preference. They've had an experience, they wish to replicate that experience, or they have an experience and they found that the side effective duration profile is not very good, and they wish to go with a different route. The peak effective period is 3 months, weak voice for 7 to 10 days, liquid food swallowing difficulties for 1 to 3 days. And that is what I would consider an optimal dose and an optimum treatment effect that we would be shooting for. Dosing usually remains constant over time. If you look at a patient group over a long period of time, 5 or 10 years, you'll find that there's a diminished need for Botox dose over time. And that is likely related to kind of a cumulative effect of Botox over time, which would reset if you stop the Botox. But remember that the recovery from a Botox injection involves neural regrowth. And that neural regrowth can take 2 to 4 years after a Botox injection is administered. Immunity to Botox is very, very rare. We at the NIH, we're looking for this group of patients. We found 2 in the entire country. So I've never had a patient develop an immunity. I've had patients I was concerned developed immunity and have had them tested and have not been able to find that type of finding. So the patients that develop immunity to Botox are the patients that are receiving large volumes of Botox multiple times a year. These typically are patients with limb dystonia. So these patients can receive 3 to 5 bottles of Botox, so 300 to 500 units of Botox at a time, whereas most patients that are being treated for spasmodic dysphonia are being treated with typically no more than about 2 units. Professional speakers, I've found challenging to manage. These are patients that are very intolerant to side effect, and they're very happy to come in every 4 to 6 weeks for repeat Botox injections. And I have a few of these patients in my practice. I don't really recommend it for anybody. It's a huge labor of love, of my time, of their time, and it's just a lot harder to do really small doses and get a good effect without ever having any side effect. But again, that is a treatment option for some patients. So the remainder of this talk, I'm going to try to get through in about 15 minutes. And that's to go over this study that I did with one of my medical students, Ishan Daria. Ishan was interested in otolaryngology, came to me during his first and second year of medical school. He had the summer off. He got a Gill Fellowship the Guild Fellowship helped support this study and gave him a stipend to live in the Washington, D.C. area and participate in this and a few other studies. So what we did is we looked at one-sided versus both-sided botulinum toxin injections in patients with adductor spasmodic dysphonia, and this is in a large group of people. So the goal was to learn what injection characteristics allow for the most optimal outcome in patients with spasmodic dysphonia, the adductor type. So we're looking for patients that had the longest duration of symptom relief and with the shortest duration of side effect. That's what we would define as an optimal treatment outcome. A suboptimal treatment outcome is a patient who has side effects the entire duration of their good effect, and that's bad. So again, we're looking for a differential between how long their voice is good for how long their voice gets weak or breathy. Key characteristics that we studied was the injection type, the injection dose, the duration of symptom relief as reported by the patient on their subsequent visit, the duration of side effect as reported by the patient on their subsequent visit, and whether the patient had vocal tremor. We built this study on a previous study that we did in 2002, in which we included 47 patients. This is from the Journal of Voice. Here's the reference. And the previous study found that unilateral injections had a more optimal duration of effect and side effect. And I remember presenting this back then, and I remember Peek Wu got up at the end of the presentation, asked me a question. He said, Steve, he said, so is that what you're doing? Are you like recruiting all your patients, and if they've never been treated before, beginning unilateral therapy? And, you know, the honest answer was that was the tendency based upon that data. But again, over time, patients move, they come and go in the area, and you end up taking care of a lot of different patients, and a lot of them have had other treatments. So we have a good mixture in the most recent study. So the first study was a limited group of patients. So this most recent study was published in, was it 2 years ago? Published in 2019 online, but I think it's 2020. It's a retrospective study of 272 patients that were diagnosed with adductor spasmodic dysphonia or adductor spasmodic dysphonia associated with tremor. Diagnosed using the multiple clinical tools that we talked about previously. All patients were treated with Botox, none had had surgery. Subjects were born between 1905 and 1998, includes males and females. And injection characteristics were determined clinically and modified based upon the previous effect and side effects. So patient comes in, they've been given one unit each side, and the patient said, I say, how was your treatment? I said, well, my voice was really good for a month. I said, well, did you have side effects? I said, no. I said, well, great. So let's go ahead and increase your dose a step and see if we can get a longer duration of effect and maybe not much side effect, but you may have a little bit more side effect if we increase the dose. And most patients are understanding of that. And unless they have a big presentation they have to do or some social event that they can't tolerate some breathiness, most will go along with that. And that's how doses are modified. Or the contrary, patient has an injection. How's your injection? Oh, my voice was breathy for about 4 weeks. I could hardly speak. I really had a hard time doing my job. I do phone support. It was a real hardship. And how is your, how is, you know, what about the good side of your voice? What happened after that month? Oh, it was great. My voice was great for like 6 months. And I said, well, yeah, that's probably a larger price to pay than most people would be willing to get 6 months of effect. And so the general counseling was to recommend that we decrease the dose with that subsequent injection. So the study includes all of those modulations that occur in patients over time. The smallest dose administered that we accepted into this study was the smallest dose resulting in a 3-month of benefit for at least 3 subjects. So the lowest dose that we found for unilateral injections was half a unit, and the lowest injection for bilateral injections was 0.3125 units in each vocal cord. And the patients were excluded if they were treated with doses below these. And I do have a group of patients that received less than 0.3125, so they were excluded from this study. Many of those are those patients that want minimal side effect and don't mind coming in 6 to 8 times a year to be treated. Patients lost to follow-up were excluded from the study, and the duration between the injections was not predetermined. I mean, the patients are allowed to come in whenever they want to based upon when they feel they need a Botox injection. So that aspect of the treatment interval was not controlled. The previous analysis looked at 3 broad categories. We looked at optimal effect for defined as greater than or equal to 3 months, optimal side effect less than or equal to 2 weeks. And we looked at the patients that had both optimal outcomes and side effects. And in the new analysis, we examined the effective duration in smaller increments. So we looked at patients who had effects that lasted less than a month, those that had between 1 and 3 months, those that had between 3 and 6 months, and those that had greater than 6 months of effect. And we compared adductor spasmodic dysphonia patients with those with tremor and patients who received Botox injection. We also looked at the patients who had received Botox injections for 10 or more years. So this is the result of the study. We had 272 patients were included. There were 4,023 total injections. Bilateral injections occurred in 2,700 patients, whereas unilateral injections occurred in about half. So despite the previous study, most patients ended up migrating over to bilateral injections. The average dose was 3.66 units. That's the total dose. Whereas the unilateral injections, the average dose was about 7.5 units. Minimum dose was 0.625 for bilateral, and maximum dose was 20 units for bilateral. For unilateral injections, minimum dose was 0.5 units, maximum dose was 30 units. So one of the more interesting aspects about Botox compared to any other medication that you could possibly be prescribed, whether it's an antibiotic or blood pressure medication or cholesterol medication, the range of Botox doses between 0.5 and 30 units is astronomical. And it's hard to predict which patients will need what. All you can do is start with kind of a general average and then adjust up and adjust down. Unfortunately, there's no evidence of a relationship between, say, the size of the person and the size of the larynx, or even severity of symptoms and the duration, the dose that's required for treatment. So optimal treatment effect, this again is those that were greater than or equal to 3 months. We found that the optimal effect occurred in unilateral patients in 47%, in bilateral in 55%, which is statistically significant. Anything less than 0.05 is statistically significant. Optimal side effects occurred in 77% of unilateral and 73% of bilateral. So while these numbers grossly are relatively similar because of the large number of data points that are entered, this turned out to be statistically significant. And then the patients who received both optimal effect and optimal side effect occurred in 36% of patients with bilateral injections and 33% in unilateral. So again, this is, it's unfortunate it's not 70% and 70%, but this is the way the data, what the data says. And again, this is statistically significant, even though it's only a 3% difference between the side of the dosing effect. So looking at the more subdivided groups, those who had an effect less than a month, 1 to 3 months, 3 to 6, and greater than 6. This is, we can get this one off the board real quick. Those who had more than 6 months of effect occurred in only 4 or 5% of patients. So again, a very, very rare occurrence, and 1 in 20 people or 1 in 20 injections, and this occurs in This is not statistically significant between the two sides. Those who received an effect between 3 and 6 months occurred in 30% of patients with bilateral and 26% with unilateral. That is statistically significant. And then those who had an effect between 1 and 3 months, again, 48 for bilateral and 44 for unilateral. The less than 1 month effect was not statistically significant. Those with tremor seem to follow a similar pattern as those without tremor. The biggest difference is that for those with tremor, bilateral effect was effective in 53%, whereas unilateral injections were only effective in 36%. So if you have tremor, there's a strong impetus to consider bilateral injections. Because again, tremor is modulated bilaterally, and only treating one side doesn't really affect the tremor that's occurring in the opposite side. Optimal side effect is always going to occur when you have just one muscle treated, but again, and that is statistically significant. So optimal effect and side effect profile is better with bilateral, with those with tremor compared with those who received injections that were just unilateral. So again, if I had adductor spasmodic dysphonia of tremor or saw a patient with that, I would recommend a bilateral injection. Looking at the 10-year group of patients, when comparing the average dose to within the first year to the average dose that was 10 years and beyond, there was a decrease of 1.33 units for the average dose over time. The average effect duration also increased by about a week out of a month, and that's not statistically significant, but the dose duration decrease over time was statistically significant. So 277 patients, retrospect will be reviewed. Okay, I don't need to do this again. So caveats to the study: there's no attempt in our study to standardize the injection dose. It's all based upon individual patient choice. We're not randomizing patients to different arms. We might have a stronger data set if we did, but it'd be hard to recruit patients into this who have never received Botox before. And we excluded patients who received really small Botox injections to maintain a persistent effect. And again, maybe that's ruling out a group of patients that actually had a pretty good effective period with minimal side effect. Bilateral injections are more frequently associated with an overall optimal effect side effect profile. And this is a different result from the previous study, and it's true for both the diagnostic subgroups, both adductor spasmodic dysphonia as well as those with tremor. And there was no difference between males and females. A greater percentage of bilateral injections had an effect duration greater than a month. Small decreases in injection dose occur over a 10-year period of time, associated with a slight increase in effect duration. I think I've gone through this pretty well. So these are our references, and I'm happy to answer questions.
Okay, Dr. Bielamowicz, hey, great presentation. Really fascinating information as part of the study that you did. So, a few questions that have popped in here. One I found interesting was, can you start Botox too early and have it not be effective after multiple years?
So there are some patients when the illness first presents, and I'm talking about within the first month, and I've had the opportunity to see people like that, where they've had a voice change, they think their voice is off, it sounds a little tight, it's not really severe, most people would consider it mild, but it's definitely the pattern that we're used to, especially with the adductor type. Those patients with really mild symptoms are very, very difficult to treat because it's hard to come up with a dose that's effective at knocking out the spasm that doesn't over weaken the voice. So that group of patients, if they've got a tremor, we'll do medical management, but I'll generally recommend that they do voice therapy. It might not be effective, but I think this is their problem they have, and let's come back and see you in 3 months. And they'll come back in 3 months, 6 months, and their voice is worsened. And I said, yeah, now I think we should probably go ahead and start Botox. So, but as far as having a negative effect over time because of early administration of Botox, there's no data that would support that.
Good. Interesting question here. Does Botox work when the primary diagnosis is tremor and secondary SD?
So the patients that there's the group at there's a big study now that got funded, multi-center study looking at vocal tremor, and they're trying to redefine the phenotype of vocal tremor. And I think there's a lot to be learned because there's patients that have dystonic tremor, and that group of patients can respond to Botox. But then there's the patients that just have modulation of their voice, as like I was alluding to, the Katharine Hepburn type of a person. And those patients don't typically have a great treatment response to Botox. They get a lot of side effects. They get weak. A lot of these patients are older, and they're older females, so their vocal cord bulk isn't very great. And so many of them don't respond great to Botox. So for pure essential tremor, and it can also be associated with the hand limb tremor, a little bit of a head nodding tremor. I tend to think of them more as medical management patients as opposed to Botox patients.
Okay. This person is asking, kind of comment, Dr. B. It says, I have Mage syndrome for about 15 years. I used Botox for the first 10 years, but the effect was reduced slowly through the first 10 years. So I had to change to Xeomin to get a good effect again.
Yeah, Mage is a very difficult problem. And so, again, for those that are on this webinar that don't know the illness, this is a multifocal dystonia that affects a few things. Most of the patients will have blepharospasm, so the eyes will overclose. They'll have a jaw issue, a jaw dystonia or a mandibular dystonia, and they'll also have issues, and some of those will also have spasmodic dysphonia, but not all of them. And that group of patients is very difficult to treat. You're oftentimes administering large volumes of Botox. And so the ability to kind of develop a tolerance or an immunity to botulinum toxin type A can happen because, again, the doses can be pretty significant because to treat a jaw dystonia, it's at least 60 units. And the blepharospasm tends to be a little bit on the order of about 30 units, 15 in each eye, more or less. So yeah, it adds up. It adds up very quickly, so you can easily develop an immunity.
Another interesting question. Can Botox possibly impact other areas of the face over time? Example, a tremor in the lower lip and chin, which I am unaware of unless pointed out to me. I've had Botox injections 4 times a year since 2011.
Yeah, you usually think about it as something different. And patients that have spasmodic dysphonia can go on to develop other focal dystonias or movement disorders. So I would think of that more in that line than I would that the Botox caused an issue with a tremor of a lip or chin.
Excellent. This is a question we get a lot, Dr. B, and I'm sure you do as well. This person is saying, I was diagnosed with AB type spasmodic dysphonia. How effective is Botox treatment for AB?
So in general, I've done studies on that as well. And in general, I tell patients that it's about 50% effective in about 50% of patients. There's two types of abductor patients. There are those that are persistently breathy. So you look at the larynx and it's almost always open during voicing tasks. And it's the cartilages are just widely separated. Those patients have just that's that 50% of patients where Botox tends to not be effective at all. The patients that have breathy breaks, those patients can get benefit. The ones that have tremor with abductor spasmodic dysphonia, that's another group of patients that have challenges with Botox effect. But again, the main issue with those patients that are optimal candidates for Botox is administering adequate medication in adequate durations without providing the major side effect, which is that of airway obstruction, because you weaken both of the opening muscles of the larynx. So what I typically do is I'll treat one side very heavy, like 12.5 units, the other side with 2.5, and then I'll have the patient come back in about a month or so, and then do the side that was just really small with 5 units, and then have them schedule every 3 months for alternating 5 units at a time, and that's worked really, really well, really good.
Good. I have 2 or 3 questions regarding MTD versus SD. So, Dr. B, could you briefly talk a little bit about the difference between MTD and SD? And have you found Botox to be effective for MTD?
So MTD is, I think, a larger mixed group of illnesses, kind of similar to what I was alluding to with the tremor patient, and that some muscle tension dysphonia is purely just glottal fry. So again, our famous president, Bill Clinton, glottal fry, is that muscle tension dysphonia? Well, if it interferes with voice production, then it's starting to get muscle tension dysphonia. And that's an illness that can be managed with voice therapy. There's another type of muscle tension dysphonia, which is this persistent, constant overclosure of the larynx without specific breaks. Some of those patients, if you have them do some sentences and have them really focus on getting quiet when they speak during a testing session, you can elicit breaks. There are breaks, but they're masked by the overclosure that's occurring through an entire utterance of everything they say. But if you can try to unload them, and the way we do this is usually have patients kind of exhale and then make a sound at the end of their breath, so they can't really be very loud. And then sometimes you can pick out that those patients do really have breaks. And those patients will respond to Botox just like any other patient with adductor spasmodic dysphonia. And then there's the patients that you never can elicit that, but they're just constantly tight. And I have some of those patients. I treat them with Botox. They generally require higher doses than you would have with a patient with these other focal dystonias. And you can give it a go. So again, I will. Similarly, you can also have a patient that has laryngeal spasticity that occurs after a traumatic brain injury. Those patients require really high doses, but they sound a lot like the patient that has muscle tension, really severe muscle tension dysphonia. So yeah, some of them can be treated with Botox, and I do treat those with Botox, but others are these, this mild illness that's really more of the way you use your voice, and that patient is better treated with voice therapy and can rectify the problem.
Okay, good. Here's an interesting question. If Botox generally only lasts 3 to 4 months of good effectiveness, let's say, then what's a good explanation of why some people can get up to 6 months of good effect from the Botox?
So just like the range of severity of illness is great. The range of dosing response to Botox is also great, both in total number of doses, as a total number of units required to affect a treatment, but also duration of effect. I mean, I had one patient I treated, and she got 5 years of effect. I saw her 2 or 3 times after the injection. She was as normal. She had spasmodic dysphonia, just like anybody had spasmodic dysphonia, just a good old, we mow all year person. And then she got treated, and her voice problem went away. And then I told her, I said, you're having a really odd treatment response to Botox. This is going to wear off one of these days. You'll be back. And she came back. She came back 5 years later, and we were never able to replicate that particular experience. She was thankful for having that 5-year break. But again, that's just an idiosyncratic response. So when you look at patients that come back and say, oh, my voice has been good for a year, for 9 months. How long were you breathy for? I was breathy for like a week. And it's like, wow, aren't you the lucky person? And I can't really explain why that is, but that's obviously we're always hoping to hit a home run, and we hit a home run, we want to do it in the World Series. So there you go.
Excellent. This person is asking, is stridor a possible side effect after many years of Botox? If so, what are the options to prevent it?
Yeah, so it's conceivable to paralyze the vocal cords with adductor type. I assume this is what this person is talking about.
I think so.
Yeah, it's conceivable. I've only had a couple of people ever develop this problem, but I have seen it. And you look at their larynx, and their larynx is, in fact, one lady, it happened recently, and she had tremor, and she's really bad tremor, and it's a dystonic tremor, and she responds to Botox. But she just kept coming in and saying, my tremor won't go away. Tremor won't go away. I said, okay, fine. We can treat you more. We'll treat you more. So she got 3 injections in a 6-week period of time. And then she called up and she says, I can't breathe. I said, well, come on in. Let me take a look and see what's going on. And she did not have an infection. She had paralyzed vocal cords, and they really had limited mobility. She had a really strong Botox effect. So that can happen. That will resolve with, holding additional Botox treatments. But that is something that can happen.
Okay. I think we will wrap up, Dr. B, with this question. Do you anticipate that longer-acting Botox will be available for injections?
Well, there's a couple things I've said through my entire career, okay? One, I want to know why people get spasmodic dysphonia. And number 2, can I please get Botox LA? I can't, no, I mean, I don't know. I mean, I know what the physiology is, and, the problem with it is that this medication gets, you need to have kind of a slow delivery system. And so some people have talked about that, like Peter Blasky talked about doing some implant where a patient pushes a little button and just administers really small doses of Botox into your larynx as you need. But what you really need to do is be able to packet the Botox so that it's released in a time-elapsed fashion. That would work. That would give you Botox LA. But as far as reformulating the medication based upon its neurophysiology, I don't think that's a possibility. We're just mimicking a biological system. But I think if somebody could come up with a delivery system where it was slowly, brought through some type of carrier product, then that might be effective.
Interesting. Thank you, sir. So these discussions always amaze me how fast they go, and excellent presentation, very, very helpful and useful information, Dr. Bielamowicz. We appreciate all you do for all of us in this voice condition world who live with this crazy spasmodic dysphonia. So thank you so much, and we really appreciate it, sir.
You're welcome. My pleasure.
Alrighty, so we're going to try to wrap up here. I have a couple of things, and we'll wrap up. But let me first say to all of you, I know we had a lot of questions submitted, and we didn't get to a lot of them. But as I said at the opening, we will get answers to all of those questions, and they will be part of the webinar that will be posted on our website. And there will be a link to it, and you can go into that link, and also on our YouTube channel. One quick announcement, we do not plan to have a webinar for December. We're looking at starting again in probably January, might be February, but we'll keep you informed and keep you posted on that. So no webinar for December. I really a lot of emotion about this comment. Sadly, we lost one of our board colleagues and a dear, dear friend a couple of days ago, Larry Colosser. Larry has been a stalwart. He's been a part of this organization from the very beginning in 1989. And he has contributed over the years so much in so many ways. It's going to be a hard task for us as we move forward. But as Larry said to me not many days ago, he is so proud of this organization and of what we have accomplished. And we will certainly use his support and all he put into this organization for so many years as we move forward. Certainly, we're going to miss Larry, but he will be in our hearts and our minds forever. And we will be sending an email honoring and really a tribute to Larry, his service to this organization, his service to so many in so many ways. And we expect to get that email out to all of you later today. So I would just ask everyone to please keep Larry's wife, Pam, their two sons, Larry Jr. and Stephen, in your prayers, and certainly in the days ahead as they go forward. So thank you, everyone. We appreciate all of you and your participation and all of you being part of this community. So thanks again.